So I think I saw lunch coming in the door. Do you guys want to get your lunch? Is that what that was?
Let us fix the sound. We cannot hear you.
Uh-oh.
1 second.
Happened with us down here in El Dorado that I kind of want to just tell you what I said last year and talk to you a little bit about what we've got going on down here, and then see what kind of questions you guys might have about me, what I have done as far as my career goes, what we're working on here in El Dorado, and how we are intending to be uniquely different in the family medicine residency spectrum of things in the state. So, as you know, I'm Donya Watson. I graduated from the University of Tennessee College of Medicine a long, long time ago, before probably all of you were born, about 30 years ago. And I did my family medicine residency down here in El Dorado. Um, when I went to UT Memphis, I really did not enjoy my obstetrics experience, my OBGYN experience. It was at a large metropolitan hospital, and pretty much all I got to do was deliver some placentas and sew up some lacerations and HMPs and post-ops and things like that. So when I settled on family medicine because I really didn't know, I didn't want to do OB. So I figured I could do family medicine without OB. But then when I came down here, in family medicine down here, there's a very huge obstetrics volume. So my two partners and I deliver about 600 to 700 a year, and I deliver about half of those. So the obstetrics experience in my residency was very wholesome, and I found out that I enjoyed that more than any other part of my practice. So I joined a group with two OBGYNs, and then I do family medicine, but I also concentrate specifically on women's health, and do a large volume of OB. So there was a residency here until maybe a decade or so ago, and then that residency closed because we were previously a not-for-profit hospital, and then we were owned by a for-profit hospital that found that they did not want to continue to put money into education. So we closed the residency, and we're in the process of trying to reopen that residency at this time. Um, the goal for us here, as you all know, and I'm sure you hear about this in the news and in your lectures and things, Arkansas is unique in that we have about the worst possibility for a good outcome for prenatal care that you can have in the country. And a large reason for that, in my opinion, and based on a lot of studies that have come out, is the poor access that women in rural Arkansas have to prenatal care. So, of of all the hospitals across the state, we're about 2 hours away from every other delivering hospital. So patients that come to El Dorado to have their babies are having to come an hour, sometimes up to 2 hours for their prenatal visits. And as you know, our patient population finds that to be quite a barrier to care. So there's a real it's congruent that the better prenatal care you get, the better your pregnancy outcome is going to be, because we can manage your hypertension, your diabetes, your weight gain, do the adequate testing, prevention, identify urinary tract infections, things like that. So the goal for our residency program here is so that family doctors, when they finish our program, can or cannot choose to go add obstetrics to their practice, but minimally will be able to provide adequate prenatal care, postnatal care, and contraceptive services to women in their communities. So we know that the Department of OBGYN at UAMS is doing the very best that they can to put OBGYNs out into rural Arkansas, but that has not been successful. Historically, futuristically, that is not where OBGYNs are going. They're not going out into rural Arkansas. So the state, the governor's maternal health care mandates recognize the need for family doctors to fill in that gap. So we're hoping to not detract at all from the family medicine experience and have a very rich family medicine experience, but also add in adequate prenatal, postnatal care, and contraceptive management so that women all across the state and in rural states, if you live here, you'll be able to provide that type of care for your patients. I don't feel like it's going to be a big surprise that we'll have um, a little bit more of an obstetrics experience in our 3-year curriculum than there is across the state. We're going to have 4 months of OB. So typically you're probably going to have 2 sets of people that are going to be looking in our program, people who really want to do OB and people who really don't want to do OB. And that group is probably going to self-segregate. So it's either going to be people that are really interested or not at all going to apply. But we want to be able to provide education so that you could be the kind of family doctor that you want to be. If you're really interested in hospital medicine, we've got a real good hospitalist program here. We have very good emergency department staffing, and our core faculty is very strong in all of those areas, as well as OB care. But we're going to provide you with the opportunity to learn those OB skills to provide pre and postnatal care, where maybe you might not be comfortable doing that when you leave the other programs in the state, but you may. And of course, electives are always available for you to be able to form your individual learning plan based on what you want to do. But things are just a little bit different here from other programs across the state. This is going to be a rural track program, which means your first year will be completed in Little Rock in a very traditional curriculum with the family medicine residents at the UAMS Little Rock program. And then for the second and third year, you'll move down here and live in El Dorado for your second and third years for the remainder of your training. We're not going to be doing any training as far as obstetrics and gynecology, as far as that goes, in the first year, because we're going to take advantage of the rich specialty environment for the first year to really get an exposure to what all you will be referring into and out of as doctors in your community. But then in the second and third year, that's when we're going to take that additional time for OB and the 1 month for GYN. So this has been very rewarding for me because I do enjoy the continuity aspect of obstetrics and family medicine both. It's about the best job I think that anybody could ever have. It's a little demanding at times, the nights and the weekends are a lot sometimes, but I'm also 30 years older than you guys, so I'm beginning to feel it a little bit. So I need young doctors like you to come in and begin to do all the things that we've been doing for the next generation. So what questions do you guys have about what we're doing here, what it is that I do, about choosing your residency, anything that I've done in the past that I can maybe help you with? Yes.
Can you hear me from here?
I can hear you a little bit.
Here, I'll come closer.
Okay, thank you.
So one of the questions I had was, how many people are y'all planning on having as residents?
Okay, we want to have a 4-4-4 program. That works ideally for our area. 4 per year is the perfect number, I think. And the reason why I think that's a good number is there's enough so that your call will not be any more frequent than 1 in 4, which is a reasonable call burden. Most of the call in our program will be from home, but you'll have 1 weeknight of call and 1 24-hour weekend shift of call when you're on inpatient medicine, when you're on emergency medicine, and then also when you're on OB. You'll take from home call for the UAMS clinic patients all the time. So it'll be 1 in 4 from home call, but it can be some inpatient call while you're on those rotations. The 4 for me is also, it doesn't become burdensome if one person is on vacation or one person's on an out of town rotation. And also in my mind, the year's divided up into 4 quarters. And so you'll say serve 3 months on like the safety and quality improvement committee. And then you'll have 3 months on practice-based learning. You know, we're going to rotate you through in sort of quarters so that you can get the whole experience and not really be overburdened by a whole lot at one time.
Thank you.
Oh, you're welcome. Y'all don't be scared to ask me questions because, you know, I don't want you intimidated by anything. This is for your information. Yes.
My question is, I'm from Warren and, like our OB program has shut down. Is there anything that's being done to combat, OB programs from shutting down in small hospitals? Or like maybe reopening them? Because
Yeah.
what y'all are doing is to fulfill those roles, but if it's, I don't know, go ahead.
No, I completely understand. So if we're trying to get family doctors to go out in rural areas, what are family doctors doing OB going to do if you go to Warren? I mean, that's a reasonable question. So a lot of the reason why these smaller hospitals are shutting down is because of the lack of physician staff. Really, ideally, in order to provide obstetrics coverage, you need about 3 people. To be on call 50% of the time is very difficult. So 3 is sort of the minimum group size that you need to take that skill out into a rural area like Warren. And you need about 3 doctors who are going to do it. So the model that we're hoping for is that maybe only 3 over, maybe you guys could bond over time and then go back to Warren. But at least, even if you don't deliver in Warren, even if there's just one of you there, you could work with doctors who are in El Dorado or in the nearest biggest location to you. And so patients would maybe only have to see us half the time and would see you half the time. So we want to improve access to that prenatal component, that postnatal component, good contraceptive care. We're also involved with the mobile health unit. We've got the mobile van that's going to be traveling around. It has a nurse practitioner and a nurse on it so that women who can't get to prenatal care locations currently can go to the van on their scheduled appointments to get care and access. We found in South Arkansas that one of the biggest barriers to care is the distance and the transportation. So if we can't, we're not quite there yet. We don't have enough doctors to go back and put 3 in Warren and 3 in Crossett and, another in Camden, 3 in Magnolia. We don't have those numbers yet, but the goal is to educate family doctors who can do that. But until we can get there, we want family doctors who can at least provide the basics for those patients so that, when it's time to deliver, you may have to go to El Dorado until we get enough doctors in rural Arkansas. But until that time, you can do some of your care at home. You don't have to take the whole day off work. You don't have to get a babysitter for the whole day. You don't have to spend your last $15 on gas money to come to El Dorado. We're trying to get doctors to go to where the patients are and not necessarily have to have the patients constantly coming to travel to us. That's a big, big, big barrier for patients to get adequate care. And I'm a firm believer that if you build it, they will come. So if you put 3 family doctors that can do OB in Warren, your hospital would be very enthusiastic about opening up that service line again. But you don't want to go by yourself. It's too much.
Thank you.
Mm-hmm. What else can y'all think of? Yes.
So I understand that there's not a whole lot of practicing OBs in your area, and that means that their schedules are quite full, including yours. Do you want to
Yes.
a little bit about your routine and, how many patients you have to see a day and what kind of time off you get?
Sure, sure. So, there's three of us, like I said, and minimally, I believe that three is, it is the absolute bare minimum. So I typically start my day between, 7 and 8. I go to the hospital between 7 and 8, and I make my rounds on any of my postpartum patients that have delivered, and if I'm inducing, so if I deliver about 300 a year, that means most days of the year, I have patients that are either coming in labor or scheduled C-sections that are repeat C-sections or things like that. So I allow myself an hour in the hospital first thing. And so then about 8, I go to my office and I see about 20 to 25 patients between 8 and noon. If I have any scheduled C-sections or anything like that, I try to do them during the noon hours so that it doesn't impact my clinic. Prior to taking this job with UAMS, I would start back in clinic at 1 in the afternoon. But when I took this job with UAMS, I had to reduce my clinic hours a little bit. And so I'm at the UAMS office 50% now. So over the last year or so, I've spent a lot of time doing things I've never done before, like writing grant applications and an ACGME application. And that's what I've been doing for the last year or so on my 50% UAMS time. So during this academic period of my life, I've been doing a lot of traveling for meetings like the ACGME meeting, the the residency leadership summit, lots of things like that. But my partners and I, also three is a very good number because if you're dividing the year up into 3 parts, you typically can get a vacation off at least once every 3 or 4 months. We've never had difficulty with having somebody to cover our call or, if you work it out in advance, it's really easy to take your time off. Patients do typically they really would like for you to be there for their delivery if at all possible. So I try my best not to schedule vacations during people's actual due dates. Now, if they deliver a week early or if they go 10 days late, and that happens to be when I'm on vacation, it's kind of understandable that, I can't not ever take a vacation. But I'm on call every third weekend, which is not bad. It's not bad at all. So I'm also on call on Thursday night. So I try to plan if I have inductions or things that I think are going to take longer than the work day. I try to schedule them on my call day so that I don't have extended hours on days that I don't expect. So, occasionally you do have to work longer than you expect, but it's entirely manageable. I mean, I was a single mom and I had 3 kids at 3 different schools, when they were young. And I mean, it's when you are your own boss and you're working with patients are real understanding. They're at the same stage of life that you are. So if you're a little late or they're a little bit late, the gratification that you get from being a part of that person's family in such a joyous life event is absolutely worth it. And despite everything that my kids have seen growing up, my daughter's actually in a family medicine program here in the States. So I didn't harm her too much by the time that I worked.
So, Dr. Watson, I spend a lot of time advising students on, which direction they should go with their training and how do I achieve my career goals that I have in mind. Could you speak a little more to maybe a little on the difference between training residency training between a family med, OB, or family med program with obstetrics versus an OBGYN program, and also maybe perhaps like, you know, differences in career options between those two paths.
Okay, yeah, absolutely. Well, so like I mentioned before, I hated OB when I was in medical school, to be completely honest, because I was not able to experience the continuity part of taking care of pregnant women. The continuity is, to me, it is invaluable. But for me, family medicine has turned out to be the right thing for me because I love very much taking care of that patient, knowing the mother, knowing the grandmother, knowing the grandfather, taking care of that patient, delivering the grandbaby, taking care of the grandbaby, you know, taking care of the whole family. I mean, that is, you know, that to me, I mean, I'm kind of getting a little bit, you know, little chills here just talking about it, but it's extremely rewarding. And with OBGYN, you really don't get to take care of the whole family. You may take care of your patient's mother, and you may take care of the patient's daughter in 18 years, but taking care of the whole family as a unit has been very rewarding for me. The training that you're going to get in family medicine and OBGYN is it's very different also. In OBGYN, you're going to be taking care of you know, the gynecological part. That's the part I have to do in order to get to deliver babies. I don't particularly enjoy that part. You know, that's just not enjoyable for me. The perimenopause is not a fun time to spend your afternoon talking about, and I don't enjoy that the way that I enjoy the OB experience. Also in OBGYN training, you're going to get a lot of GYN oncology. You're going to do a lot of surgery. And if you really like the surgery component, and that really stands out for you, if you're more of a surgeon and less of a family doctor, you probably don't want to go the family medicine and potentially OB path because you're going to really miss out on time in the operating room. I'm able to deliver the number that I'm able to deliver because I also don't do hysterectomy and diagnostic laparoscopy and, you know, surgery for endometriosis and bladder lifts and all those things that I don't enjoy at all. But I do get to do the full scope of family medicine and OB because I have that additional training that I do my own C-sections, I do cryo, I do LEAP, I do postpartum tubules, I do, you know, surgery for miscarriages, things like that. I get to do all of the obstetric part of the OBGYN formula. So the American College of OBGYN, you can't really put gynecologists out in rural Arkansas because there just aren't enough uteruses. I mean, you know, there's only so many uteruses that there are to take care of out here. And after half of them are taken out, there's not enough people out here to support a lot of GYN cases out here. So you can't really blame OBGYNs for not going out into rural Arkansas because they don't really get to use that second half of their skill set if they go out in rural Arkansas. But as family doctors, we don't really use that other GYN part. And typically there's a gynecologist somewhere locally that you can refer to. But to me, it's very important to train family medicine doctors to be able to take care of the degree of risk that you are going to be associated with in rural Arkansas because you don't have OBGYN backup all the time. But you need to know how to do the basics. And so if you're working in the ER or in Warren in the ER, if you're a family doctor in ER and you got a patient that's got the flu, that, you know, you need to know how to take care of. A family medicine program that gives you good training in all the different kinds of normal physiologic conditions, which includes pregnancy. You're going to be able to take care of just about anything that comes your way in rural Arkansas. So that's the reason why that was way more beneficial to me. as far, and the difference in training is that, you know, you're not gonna do all the GYN in a family medicine residency. You're just not gonna, you're not gonna have exposure to that. You'll have a month of it, but that's gonna be about it. But if you're leaning towards the surgical part, the family medicine with OB is probably not the best path. I mean, I spend a lot of time in the OR, but not anywhere near what my partners spend. They each have like one whole day dedicated to surgery a week, and I don't do that. I'm in the OR probably 3 to 5 times a week, but it's not like a whole day out of my clinic or anything. What else can y'all think about?
Dr. Watson, can you talk a little bit about the difference between OB training in family medicine residency and an FMOB fellowship? And
I was so hoping one of you guys were gonna ask about that. So we are going to have a family medicine pregnancy care fellowship here in El Dorado, and that's going to start in July of 2025. That'll actually be here a year before we expect our residents to arrive, which will be July of 2026. So this program is for a family physician who has completed a ACGME program, a 3-year program, and is ready to sit for the boards and would like additional training in obstetrics for independent practice. So the American Board of Medical Specialties recommends that in order for you as a family physician to be competent to be independently in practice of OB, that you should have about over 100 to 150 vaginal deliveries and at least 50 C-sections as the primary surgeon. Across the state, those numbers are difficult to get in the family medicine programs that are currently in place either in Little Rock or across the rest of the state. Our candidate that's going to be starting in July, she has over 100 vaginal deliveries, but she is not yet trained as the primary surgeon for cesareans because she's having to compete with residents in her training location. So she's going to come to train with us, and she's going to learn over a year's time how to do primary C-sections and repeat C-sections and take care of high risk. So it is an additional level of training that's over and above the obstetrics training that you get during your residency. So we do not yet have that in place in the state of Arkansas currently. So we're going to start that in July. We're not going to call it an OB fellowship because our OBGYN counterparts do not enjoy that. And so it's a little bit less threatening if we call it a family medicine pregnancy care here. So what we're doing is expanding the basic family medicine training that a candidate would have so that he or she is qualified for independent obstetrics practice at the completion of that year. When I finished, I had adequate training during my residency that I did not require an OB fellowship year. But that was because none of my co-residents wanted to do anything with OB. And so everything that had to do with OB, I got to do. So I had adequate training. Now the ACGME says that you guys got to spread that around. You got to do it sort of equally. And you'll get a minimum in a family medicine residency, but in some programs, it will really only be the minimum. So you would want to choose a residency, if you plan to do this, you would want to choose a residency that has high OB volume, and you would like to accomplish as much as you can during your 3 years so that during your fellowship year, your family medicine pregnancy care fellowship year, then you can further refine your skills and be very, very sharp for independent practice. Does that answer the question?
Yes, thank you.
Mhm.
Hi, Dr. Watson.
Hi.
I'm an M1 and I have had some experiences shadowing family med docs and OB-GYNs, and I find myself really drawn to both of them. How do you
Yes.
recommend as M1s, M2s, kind of really before we get clerkship clinical experience, do we kind of go about perhaps getting more experience, seeing the differences between the two fields?
Yeah, so there is a summer clerkship between your M1 and M2. I don't know what they call it. Dr. Stone, maybe you can help clarify. But for example, I had someone who sort of felt the same way that you did. And she came down for a couple weeks in the summer and spent some time with us to kind of see the difference between what actual OBGYN clinic looks like and what does a rural family medicine OB clinic look like. They're distinctly different animals. They're totally different. And I think that it's really valuable to get to see both. Anytime you guys have any free time, you don't really get much free time, I know that, but anytime you have free time, even if it's outside of the UMS system, my private office is South Arkansas Women's Clinic. And so if you have time, you can come anytime to stay a day or two, just take a look and see what the differences are. I'd be happy to work with you guys during your UAMS time, and your time outside of UAMS in the private clinic. It's really important to me that you do get to see both because they really are a whole lot different. My two partners are OBGYNs and we work together very well. But they do a lot of things that I don't enjoy, that surgical part. I don't enjoy that. And it would be good for you to see what we do versus what they do.
Thank you.
You're welcome.
What Dr. Watson was mentioning is our M1 summer program or preceptorship. We'll be sending out information in January about that. So it's a 2-week opportunity in the summer. You can go work with Dr. Watson or any of our rural family medicine physicians around the state, and we'll give you a $500 stipend as well.
So I want to clarify something that I said, and I oftentimes say things that don't sound the way I want them to say, but when I said our OBGYN counterparts don't like us to call it an OB fellowship, this program that we're starting is fully endorsed by Nirvana Manning in the Department of OBGYN. They are very much in support of this. It is one of the things that the governor identified as one way that we can reduce maternal morbidity and mortality is to develop an OB fellowship and put family doctors out in rural Arkansas. I just don't like to, I don't want to take the specialty of OB and make it family medicine OB. I don't want to take any ownership of it away from our OBGYN colleagues. We certainly need our OBGYN colleagues. It's just that we also need family doctors who are competent in the prenatal, postnatal care, and contraceptive care, because not everybody has access to an OBGYN. A lot of people in South Arkansas don't have access to a primary care provider at all. So as a family physician, it's real important that you understand how to do that part also. And you'll learn that. It's just very important to me that somebody somewhere is doing something to address this disparity that patients are facing.
Dr. Watson, to that point, could you share a little about the obstetric patients that you might feel better in handing off to one of your OBGYN colleagues, certain conditions that high risk that you would refer to one of your partners?
Yeah.
Or to
So,
the big medical, the academics.
yeah. So when I was a young doctor a long time ago, Patients that were exceedingly high risk here, I would manage those in consultation with my OBGYN counterparts. Patients that sort of exceeded routine OBGYN expectations to manage a high risk pregnancy, those we did refer to UAMS, and that is something that we still do. We have a very good relationship with the maternal fetal medicine department here. We have a good relationship with Dr. Manning and her staff. We also have a very good relationship with the high risk group at Baptist. But as times have changed during my career, a low risk pregnancy in rural Arkansas is a very rare thing. We are facing record numbers of patients with chronic hypertension, diabetes, morbid obesity. And so there really is not a way to refer all of those high-risk patients up to the medical center, because they not only can they not get to El Dorado, they really cannot get to Little Rock for all their care. So we work with the Department of High-Risk OB. And so for high-risk maternal fetal medicine consultations, we can do those via telemedicine here. And so they get their ultrasound, they're here in El Dorado. The high-risk doctor watches the scene, gives us recommendations, interprets the ultrasound. And then along with them, we co-manage those so that people don't have to drive. Now, we are facing patients that approach 500 pounds. We are not able to take care of here. We do not have beds, bariatric beds in the operating room whereby we could handle those. So approaching 500 pounds, we are having some challenges with that. So those patients at the end of their pregnancy are referred for transfer of care. But typically, amongst the three of us with high-risk consultation, we can keep patients at home once they reach 32 weeks and after. Now, if a high-risk patient is going to need to be delivered prior to 32 weeks, we usually have to go ahead and transfer those patients because of the neonatal needs. We don't have a neonatology here. We have great neonatal nurse practitioners, pediatricians, family doctors who take care of these babies, but prior to 32 weeks, we just don't have the resources to take care of those babies. And the safest place to transfer that baby is in the mom. So if you have an opportunity to make that transfer prior to 32 weeks, that's the best thing to do. But they are always available to help us out with our high-risk patients and in consultation. And it's a very good relationship. You know, it's not adversarial in any way. That's why I wanted to be sure to disqualify what I said. I'm not trying to do anything that the OBGYN department doesn't approve of. I just want to make it a bit more friendly. We don't want to compete. We're all on the same team. But just to say something else, if you decide you love El Dorado, which I think you would if you came to visit, but you didn't necessarily want to incorporate independent obstetrics into your practice, that's not a problem. You don't have to do a minimum of 80 deliveries. You don't have to do anything like that. You have to complete your 20 exposure according to the ACGME guidelines. But we can, on your individual learning plan, we can make sure that we get you extra time with the hospitalist group, extra time in the ICU if you want to do that. You can spend extra time on your electives. You have 6 months of electives between your second and third year, and you can spend that time enhancing your skills in the emergency department. You can enhance your skills in a primary care clinic. So this additional OB time and what I want you to learn about prenatal, postnatal care, and contraception should not and will not take away from your ability to become whatever kind of family doctor you want to be. You know, typically there's different kinds now, you know, clinic-based, hospitalist, emergency department. Everybody's doing something different, but regardless, we're all on the same team, and we want to make sure that not only do our patients get what they need, but you as students when you become residents, get, a residency experience that you need to become the kind of doctor that you want to be.
We're nearing 1 o'clock. Any final questions for Dr. Watson? Dr. Watson, thank you so much for joining us today and bearing with us with our audio issues at the beginning of the meeting. Happy that you joined us and let us learn a little bit more about your residency program and the new fellowship program. I think everybody's really excited about that. So,
So
again,
my email is dwatson and the same ending that all y'all have at ums.edu. So if you have any questions or concerns or want to contact me in any way for anything, dwatson should be easy. Now I appreciate you guys listening to me because obviously you can tell I can talk a lot, too much. Sorry.